السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. أبناء الطلبة والطالبات الفرقة الخامسة بكلية طب المنصورة، يعني تحية طيبة. إن شاء الله النهاردة هنستعرض محاضرة قيمة جدا of practical significance، وهي Ascites and Hepatorenal Syndrome. The meaning of ascites, it is a Greek word meaning bag or sac. Pathologic fluid accumulation within the abdominal cavity, which is a common complication of liver cirrhosis. Pathophysiology of ascites, you know that the capillary bed have arterial end or venular end, and there is two forces that judge this filtration and reabsorption. Filtration occurs at the arterial end and reabsorption occurs at the venular end by Starling law, hydrostatic pressure and oncotic plasma pressure, which depends on serum albumin. According to Starling hypothesis, the exchange of fluids between the blood and tissue space is controlled by the balance between two factors: capillary blood pressure, osmotic pressure of plasma protein, plasma colloid osmotic pressure. In portal hypertension, there is increased capillary blood pressure and decreased plasma colloid oncotic pressure, which depends on albumin, so they lead to ascites. يبقى ascites يبقى fluid accumulation at the peritoneal cavity due to develop ascites. Two prerequisites: first, increase portal hypertension; next, decrease serum albumin. According to pathophysiologic mechanism for development of ascites, we divide the etiology of ascites into: first, increase the hydrostatic pressure in cases of cirrhosis, hepatic vein occlusion, as in Budd-Chiari syndrome, inferior vena cava obstruction, constrictive pericarditis, congestive heart failure. Decreased colloid oncotic pressure in end-stage liver disease, in nephrotic syndrome with protein loss, malnutrition, protein losing infancy. The third cause of ascites, increased permeability of capillaries in case of tuberculous peritonitis, bacterial peritonitis, malignant disease of the peritoneum. The fourth cause is leakage of fluid into the peritoneal cavity, as in cases of bile ascites, pancreatic ascites, chylous ascites, urine ascites. Miscellaneous causes of ascites, as in cases of myxedema and chronic hemodialysis patients. Mechanisms of ascites: there is underfill theory, overfill theory, vasodilatation theory, like this. The most recent theory is nitric oxide theory, peripheral arterial vasodilatation. When a portal pressure increases above a critical threshold, nitric oxide level increase, leading to vasodilation. As the state of vasodilation worsens, plasma level of vasoconstrictor and sodium retaining hormone increase, and renal function deteriorate with the development of ascites. How to evaluate a patient with ascites? First, clinical evaluation depends on history taking, general examination, local abdominal examination, then investigations. History, the most important items: age, sex, order of development of ascites. Age: in childhood, we should think about tuberculous ascites and nephrotic ascites. Middle age, we should think about liver cirrhosis. In old age, we should suspect malignancy. According to the sex, female, when a female presents with ascites, female in presenting with ascites, you should exclude mixed syndrome. mixed syndrome بيبقى فيها ايه ovarian tumors وبيبقى معاها peritoneal seedling و ascites development. Next, pelvic tumors and infection and ovarian tumors. The order of development of ascites, which develop first. In cardiac ascites, leg edema precede ascites. In renal cause of ascites, buffness of the face precede ascites. In hepatic ascites, ascites develop is the first feature. Ascites is the first feature. Ascites is a part of generalized anasarca caused by nephrosis, anemia, hypoproteinemia. In general examination, we should look for enlarged lymph nodes, associated jaundice, dyspnea, paroxysmal dyspnea, orthopnea, edema, periorbital edema, severe anemia, other signs of malnutrition with ascites. Local abdominal examination, we should inspect the abdomen. There is abdominal distension. The umbilicus is everted and slit transverse, laving umbilicus, and shifted down. The distance between umbilicus and the sternum is more than the distance between the umbilicus and the symphysis pubis. Flanks are full. Flanks are full. For flanks to be full, at least 1,500 milli fluid is required to make the flanks full. Veins are dilated over the abdomen. Scrotal edema indicate nephrotic syndrome. Palpation of the abdomen, tenderness and local rise of temperature signify peritonitis. Rebound tenderness or Blumberg sign signify peritonitis. Doughy or rubbery feel of the abdomen indicates tuberculous peritonitis. Presence of splenomegaly, ascites, and decapitated mucosa in hepatic ascites. Enlarged tender liver and ascites, congestive cardiac failure. Palpation of interabdominal masses, we should exclude TB. Palpation of lumps and enlarged glands in cases of TB, malignancy, leukemia, Hodgkin lymphoma. Veins over the abdomen. When we found dilated veins over the abdomen, we should differentiate between whether it is of portal vein obstruction or hepatic vein obstruction or inferior vena cava obstruction, as you show in this figure. The onset of ascites is significant. Signs, the previously mentioned signs of abdominal examination in case of insidious onset of ascites. But in sudden or rapidly accumulating ascites, the other features not prominent. What is the etiology of acute developing or rapidly developing ascites? Remind acute Budd-Chiari syndrome, acute right heart failure, sudden decompensation of previously compensated cirrhosis. We should think about HCC on top of liver cirrhosis. Also, pancreatic ascites. On the other hand, insidious or gradually developing ascites in cases of decompensated cirrhosis, chronic Budd-Chiari syndrome, tuberculous ascites, nephrotic syndrome, hypothyroidism, constrictive. Demonstration of ascites. 5 classical physical signs. Bulging flanks, belly of a frog, flank dullness or horseshoe dullness, shifting dullness. It is of high sensitivity and low specificity. Fluid wave or fluid thrill. This is the sure sign of tense ascites. A puddle sign, Lawson sign, decreased auscultation of high frequency vibration in the central abdomen when flicking the side of the abdomen, when the patient assume knee elbow position. Grading of ascites. Clinically, we divide ascites into 3 grades and according to severity, mild, moderate, severe, and signs. In mild cases, Badal sign; in moderate cases, shifting palms; in severe cases, fluid cerebral with respiratory imbalance. Minimum amount of acidic fluid required. When we take a diagnostic acidic fluid tab, we need around 10 to 20 milli of acidic fluid. To elicit Badal sign, there should be 120 milli of acidic fluid in the abdomen. Shifting dullness to be evident when there is at least 500 milli of acidic fluid. Fluid cerebral if there is tense ascites, at least 1,500 milli. The minimal amount detected using abdominal ultrasound is 100 milli, and also by CT scan. Diagnosis. After diagnosis of ascites, its cause should be determined by lab analysis. We should do acidic fluid study by diagnostic parameters. 10 to 20 milli. The bladder should be emptied prior to the procedure. Most common side left lower quadrant. Other side in the umbilicus, in the midline between the pubic symphysis and the umbilicus. Right iliac fossa lateral to the inferior epigastric artery or a few centimeters of the inguinal ligament. And we should do the technique like this, as illustrated in the figure. Contraindication of ascites: severe coagulopathy, abdominal wall hematoma, local infection. There is relative contraindication if there is repeated surgeries. What are complications of ascites? Acidic fluid is liable for infection and spontaneous bacterial peritonitis. Complications of abdominal paracentesis, infection and peritonitis, bladder or bowel perforation, hypovolemia and shock. If we removed more than 1 liter rapidly, especially if the patient does not have edema. If complication, if there is blockage of needle. Diagnostic acidic fluid sampling is essential to test. There is routine test and optional test and unusual test. What are the routine tests for acidic fluid? Cell count and differential count, albumin concentration and total protein concentration, culture in blood culture bottles. What are optional? Certain tests are done according to certain situations. Glucose concentration, lactic dehydrogenase concentration, gram stain if we are suspecting there is infected acidic fluid, amylase concentration if we suspect as a pancreatic ascites. Unusual acidic fluid testing like test for TB by tuberculosis smear and culture and adenosine deaminase. We should do cytology if we suspect malignancy. We should do triglyceride concentration in case of biliary ascites and bilirubin concentration also. Ascitic fluid color. If the color is true colored or transparent, this could be in case of cirrhosis and tuberculosis. Bloody fluid in case of malignancies, trauma, TB, peritonitis, pancreatitis, perforated viscous, traumatic tab, opaque or milky, chylous ascites, dark brown in case of biliary ascites and jaundice, black or tea color ascitic fluid in case of pancreatic ascites and malignant melanoma. Cell count. White blood cell count is the most important. Normally, white cell count less than 250 per cubic milli. In cases of uncomplicated cirrhotic ascites, white cell count less than 500. In case of spontaneous bacterial peritonitis, white cell count more than 500. In case of tuberculous ascites, it is also raised. A differential cell count, normally lymphocytic. In cases of cirrhotic ascites, polymorph, uncomplicated cirrhotic ascites, polymorph less than 250 per cubic milli. In case of spontaneous bacterial peritonitis, polymorph nucleocytes more than 250 per cubic milli. This is diagnostic for spontaneous bacterial peritonitis and cirrhotic ascites. In case of tuberculous ascites, the differential count is mainly lymphocytic. Also, RBCs is significant if there is more than 50,000 cells in case of traumatic ascites or malignant ascites. What is the difference between oxidative ascites and transudative ascites? This table demonstrates this difference. What is serum to acetic albumin gradient, SAG? Serum to acetic albumin gradient. SAG equal to serum albumin minus acetic fluid albumin. The gradient correlates directly with portal pressure. A gradient more than 1.1 gram per deciliter. This indicates that ascites is due to portal hypertension, high gradient, or transudative ascites or portal hypertensive ascites. A gradient less than 1.1 gram per deciliter, low gradient or oxidative or non-portal hypertensive, suggests that the ascites is not due to portal hypertension. Specificity and sensitivity of SAG around 97%. SAG is far superior to the old exudate-transudate concept. SAG does not explain the pathogenesis of portal hypertension. So, the most significant test to be done for ascitic patient is serum to ascites albumin gradient, what is called SAG. Classification of ascites based on SAG. There is high gradient ascites and low gradient ascites as demonstrated in this table. Image. The most important and extremely sensitive is abdominal ultrasound. It detects as little as 100 milli. Also, abdominal CT. And the main significance of abdominal CT is to differentiate malignant from other causes of ascites. Malignant ascites. What are the features of malignant ascites? If there is associated abdominal lymph nodes, if there is focal hepatic lesion, if there is splenic lesion, if there is pancreatic and colonic masses, and when suspect malignant ascites, which rapidly filling ascites, more useful than abdominal ultrasound in detecting hepatic lesions, and differentiating hepatic focal lesion if it is primary or secondary by what is called triphasic CT study. What are complications of ascites? Acidic fluid in the peritoneal cavity is liable for spontaneous bacterial peritonitis. The patient is liable for hydrothorax, especially on the right side, right pleural effusion. This is associated in abdominal ascites. Gastroesophageal reflux, respiratory distress and atelectasis due to elevation of diaphragm, inguinal, umbilical or femoral hernias, scrotal edema, collection fluid in the pleural sac, mesenteric venous thrombosis, functional renal failure, what is called hepatorenal. What is the meaning of spontaneous bacterial peritonitis? Spontaneous bacterial peritonitis characterized by spontaneous infection of acidic fluid in the absence of an intra-abdominal source of infection. It occurs in 10 to 30% of hepatic ascites. Equal sex distribution. Before the age of 6 years, most common. Most cases occurs in children with ascites, especially with nephrotic syndrome, cirrhosis, and infection. Spontaneous bacterial peritonitis white cell count more than 500 per cubic milli, and the polymorph more than 250 cells per cubic milli. What is the value of acidic fluid study in differentiating causes of ascites? This table demonstrates this. As regard acidic fluid color, protein content, SAG, RBCs, white BCs. And each category of each etiology have its own characteristics. What are treatment modality for ascites? Treatment options: bed rest, diet, diuretics, fluid restriction, paracentesis, TEPS, chance transplant. Management of ascites. First, sodium restriction. The aim to restrict sodium down to 2000 milligram equal to 88 millimole per day. يعني البيشنت not receiving sodium more than 2000 milligram per day. Studies show severe restriction equal to 22 millimole per day compared with less restricted is associated with longer duration of evolution of ascites, but higher incidence of diuretic-induced renal impairment and hyponatremia. يعني severe restriction is not recommended. Next step is diuretics. What are kinds of diuretics used for treatment of ascites? First, antimineralocorticoids. As in cases of ascites, there is secondary hyperaldosteronism leading to salt water retention. So we give antimineralocorticoids. What are the available drugs? Like spironolactone, aldactone. Effective anti-mineralocorticoid. السايد افكتس بتاعته جاينيكوماستيا في الميل يعني طبعا، ورينال امبيرمنت، هايبركاليميا. Other drugs than spironolactone and also potassium retaining diuretics like amiloride or trimetrin. The second drug for treatment of ascites is loop diuretics like furosemide. Side effects of furosemide: hyponatremia, hypokalemia, hypovolemia, renal impairment of perirenal origin. How to assess response to diuretic therapy? We should weight the patient. There should be weight loss of 0.5 kg per day in absence of edema and 1 kg per day when edema is present. Use spironolactone and furosemide 100 mg and 40 mg ratio. Medical treatment based on sodium-restricted diet with diuretics gives response in 90% without renal failure. What is the meaning of refractory ascites? Diagnostic criteria for refractory ascites: lack of response to maximal doses of diuretics for at least 1 week. What is the maximum dose of diuretics? 400 mg spironolactone to 160 mg furosemide. يبقى if the patient received 400 mg spironolactone and 160 mg furosemide and no response at least for 1 week, this indicates refractory ascites. Diuretic-induced complication, if arised in the absence of other precipitating factors. Early recurrence of ascites within 4 weeks of fluid mobilization. يعني if the patient received treatment and within 4 weeks he ascites reaccumulate. This is refractory ascites. Or there is persistent ascites despite sodium restriction. Or if there is weight loss less than 0.8 kg over 4 days and urinary sodium excretion less than sodium intake. All these 6 criteria are criteria for diagnosing refractory ascites. What are the therapeutic options in refractory ascites? First, chronic outpatient paracentesis. Next, ascites, ultrafiltration and reinfusion. Third, leave-in shunt, peritoneovenous shunting of acetic fluid to the general circulation. Tips: transjugular intrahepatic peritoneal shunting. Liver transplant. This is the last option. What is the meaning of therapeutic paracentesis? First, indications: tense ascites that cause respiratory embarrassment, intractable ascites not responding to the usual treatment. Third, to release intra-abdominal pressure in moderate to severe ascites. Large volume paracentesis up to 200 to 400 milli per kg per day can be removed slowly over 4 to 6 hours if the patient has peripheral edema. Large volume tap more than 5 liters plus intravenous colloid replacement with albumin 6 to 8 gram per day. Dextran 70 gram is less effective than albumin. What is the meaning of hepatorenal syndrome? We should define hepatorenal syndrome and know what types of hepatorenal syndrome, what is the etiology, what is the diagnostic features, what is the differential diagnosis, what is the treatment options, and conclusion. Hepatorenal syndrome is the development of renal failure in patients with advanced chronic liver disease, that say portal hypertension due to cirrhosis or severe alcoholic hepatitis, or less often metastatic tumors. Hepatorenal syndrome occasionally happens with fulminant hepatic failure who have portal hypertension and ascites. The pathogenetic mechanism, as illustrated in this diagram, progression of liver failure and portal hypertension lead to increased arterial vasodilation, leading to decrease effective arterial blood pressure and moderate sodium retention, both leading to severe water retention and hyponatremia. Also, when combined with central hypovolemia, leading to decreased carb output, leading to secondary water and sodium retention نتيجة stimulation of what is called mineralocorticoid secretion, secondary hyperaldosteronism, leading to water retention and sodium and hyponatremia. What are the types of hepatorenal syndrome? We should differentiate between two types, type 1 and type 2. Type 1, there is increase in serum creatinine more than 2.5 milligram per deciliter, or 50% decrease in creatinine clearance, يعني less than 20 milli per minute during a period of less than 2 weeks. يعني الdeterioration ده حصل in a period less than 2 weeks, rapidly progressive of very poor short-term outcome. While type 2 increase in serum creatinine more than 1.5 milligram per deciliter without meeting criteria of type 1. And in this type, there is refractory ascites, and this type 2 is slower progressive than type 1, and prognosis is not bad as type 1. As we found, type 1 is worse than type 2. What are the risk factors for development of hepatorenal syndrome in a patient with hepatic ascites? It may happen spontaneous without any explanation, but there are many triggers as diuretic resistant ascites. When we face a patient not responding properly to diuretics, we should put in mind the possibility that that patient with hepatic ascites sooner will develop hepatorenal syndrome. Next, if we did large volume paracentesis without albumin replacement, this is constitute 15% of cause. Also, as a complication for spontaneous bacterial peritonitis in 20% of cases. What are the major criteria to diagnose hepatorenal syndrome? Advanced cirrhotic hepatic failure and portal hypertension. Serum creatinine more than 1.5 milligram per deciliter, or 24-hour urine creatinine clearance less than 40 milli per minute. Absence of shock, يعني we should exclude other causes of renal failure. Absence of shock, massive GI or renal fluid losses, exposure to nephrotoxic drugs or hypovolemia, or ongoing sepsis. No sustained improvement in renal function following a fluid challenge by volume expansion with 1.5 liter of isotonic saline. If there is proteinuria less than 500 milligram per deciliter. If there is no evidence of obstructive uropathy or parenchymal renal disease. These are the major criteria to diagnose hepatorenal. What is the minor criteria? If urine volume less than 500 milli per day, urine sodium less than 10 milli equivalent per liter, urine osmolality more than plasma osmolality, urine RBCs less than 50 per cubic high-bar filled, serum sodium less than 130 milli equivalent per liter. Differential diagnosis from other causes of renal impairment. What is the treatment options for hepatorenal syndrome? The patient should be hospitalized in ICU, intensive care unit. Initially, we have to start norepinephrine 0.5 to 3 milligram per kg with the goal of rising mean arterial pressure 10 millimercury. Next, albumin for at least 2 days. We start to buy 1 gram per kg per day or 100 gram maximum. we remind you that a bottle of human albumin is contain 25 gram albumin. So we start to buy 4 bottles of albumin per day. IV vasopressin may also be effective, starting at rate of 0.01 unit per minute and titrating upward as needed. Patient not in ICU, we use terlipressin and albumin. Terlipressin 1 to 2 milligram every 4 to 6 hours, and we use albumin for 2 days as mentioned before, 1 gram per kg per day, 100 gram maximum, followed by 25 to 50 gram per day until terlipressin therapy is discontinued. In patients who fail to respond to the above therapies, develop severely impaired renal function, or are candidate for liver transplant, or have a reversible form of liver injury, or are expected to survive, the recommendation is to start dialysis as a bridge to liver transplant or liver recovery. So the conclusion is hepatorenal syndrome can happen with advanced chronic liver disease and also with fulminant hepatitis. Diuretics will cause azotemia but not hepatorenal syndrome. Hepatorenal syndrome diagnosis needs good history, clinical diagnosis after exclusion or other causes of renal impairment. Starting medical therapy depends on drug availability and patient position, ICU versus medical ward. Tips: transjugular intraperitoneal portosystemic shunting should be considered as a last resort because of most patients are not suitable for operation, numerous complications related to the procedure, and needs for chronic renal replacement therapy before and after the procedure. Chronic renal replacement therapy should be started for patients expected to respond to medical therapy or as a bridging to liver transplant. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.